Hi, this is John Goldblum, and I'm going to give a little discussion about some of the, I find, the confusing areas of colorectal polyps. This is not going to be a discussion of every kind of colorectal polyp, but I just want to hit on a couple of main points that I find that people struggle with, including myself. Some of this is related to just bad nomenclature. In areas of disagreement, I will give my own personal bias, which may or may not be correct. It's just my own bias. So colorectal polyps. This is just a partial list of some of the colorectal polyps that we see pretty routinely in the GI tract. Obviously, the ones we see most commonly are hyperplastic polyps and your regular old adenomatous polyps, which I'll certainly talk about. One of my least favorite topics in GI pathology is this one. I can't avoid talking a little bit about the serrated lesions, so-called sessile serrated polyp, or some people prefer the term sessile serrated adenoma. Those two terms are entirely equivalent and have been accepted by the WHO as equivalent terms. We, in our own practice at the Cleveland Clinic, use the term sessile serrated polyp, and our clinicians know exactly what we mean when we use the term sessile serrated polyp. And so all of our GI pathologists use that term, even though I know that there are GI pathologists at other institutions that prefer the term sessile serrated adenoma, and that's fine. Then the other serrated lesion we see, certainly far less frequently, are the so-called traditional serrated adenomas. Just because it's got the word serrated in its name doesn't mean it's the same thing as a sessile serrated polyp, and in fact we know this is a different lesion, but this can cause a little bit of confusion. So you have to have some experience and familiarity with the nomenclature to know what the difference is between a sessile serrated polyp and a traditional serrated adenoma. They actually look morphologically quite distinct from one another, as I will discuss. And then we see a reasonable number of inflammatory polyps, certainly in the setting of inflammatory bowel disease, but also in other settings. We also see a certain number of hamartomatous polyps, juvenile polyps, Peutz-Jeghers type polyps. Those are less common, but we see them on occasion. One of the things that we see not infrequently on an everyday basis, actually, is when they say there's a polyp and there's nothing there other than a lymphoid aggregate, I always conclude, or at least make the assumption, that it's the presence of the lymphoid aggregate which caused the endoscopic appearance of a polyp. And then, of course, you won't find this in any textbook or classification of polyps. There's the polyp that gets cauterized beyond recognition, and we see this with some regularity too. And sometimes the best you can say is severely cauterized colonic mucosa, and you might be able to favor a hyperplastic polyp or maybe favor a tubular adenoma, or sometimes you can't favor anything because it's so darn cauterized you just can't say anything with any degree of certainty. So let's start off and talk a little bit about just the regular old adenomatous polyps. Now, to make an important point, and I know this seems obvious, but to be honest, it's not entirely obvious to a lot of gastroenterologists that I've talked to, is that the term adenoma is equivalent to dysplasia. So whenever you call something an adenoma or tubular adenoma, you're saying it's got at least low-grade dysplasia. And this is a run-of-the-mill tubular adenoma that has low-grade dysplasia. It's got these very characteristic pencillate nuclei with a little bit of stratification, but notice that the nuclei are generally restricted to the lower half of the crypt, and that's pretty characteristically seen in a regular old tubular